was very nice and clear presentation. Before we proceed to our next speaker, may I ask all our participants to put their questions in the section for question and answers so that we can present them to the speakers at the end of the session. Now we proceed with Professor Marwa Eldeeb, Professor of Pediatrics, Ain Shams University, who will be talking to us about the Chamber of Secrets. Please, Professor.
Thank you. Thank you very much, Dr. Mohammed, for the very kind presentation. Thanks to all the pediatric ICU team, and thanks to my friend, Dr. Nihat, for this very interesting presentation for this case. My name is Marwa Eldeeb. I'm Professor of Pediatrics at Ain Shams University. So what's the Chamber of Secrets? The Chamber of Secrets is the GIT. And why is the GIT Chamber of Secrets? Because almost all of GIT symptoms are diverse, vague, non-specific. They overlap and coexist with many other systems. And a simple example is vomiting, for instance. It could accompany a simple case of gastroenteritis, and it could be a presentation of a more serious CNS condition. And that's the case with almost all GIT symptoms. So what's the solution to this? The answer to this is to stay focused. We need always to stay focused. We need to try and spot the elephant in the room. And the elephant in the room, in my opinion, is the very strong symptom that lead you to suspect GIT involvement in the disease. And actually, in this case, there were many elephants in the room. So if I would summarize this case, as Nihat said, this patient, before presentation to the ER with this very severe condition of cardiogenic shock, he presented with fever, abdominal pain, arthralgia, and weight loss 2 months before presentation. And this trio is very famous in GIT diseases: fever, abdominal pain, and weight loss. This is a very famous trio. It was your first elephant in the room from the presentation of the patient. I'll take it from here. Nihat did a very good job taking it from the fever, and I'll take it from the chronic abdominal pain view. Chronic abdominal pain, by definition, is any long-lasting or intermittent pain that interferes with the patient's daily activity. And again, because it's one of the GIT symptoms, it's vague, it's non-specific, it's diverse, and it overlaps and coexists with many other system presentation. GIT could be the cause. We have multiple non-GIT causes, and we have functional abdominal pain disorders in which we could not spot an anatomic or structural or biochemical abnormality. If I give you a quick review on the GIT organic causes, if the pain is mainly upper, so it's supraumbilical, we're thinking of acid peptic disorders, infections as giardiasis or maybe typhoid, hepatobiliary stones or hepatitis, or even chronic pancreatitis. If the pain is infraumbilical, so we're thinking more of IBD, inflammatory bowel diseases, infections, again, as TB or Yersinia, or surgical cause. If the pain is diffuse and the patient cannot localize, so again, infections could be the cause, but we could more think of other malabsorption disorders or even allergic disorders. If we want to think outside of the GIT, it could be because of renal pathologies. If she's a female, we have multiple gynecological causes, toxicity or metabolic disorders as the porphyria, or autoimmune disorders. On top, of course, are the periodic fevers. This is the functional abdominal pain disorders. There are a group of disorders in which we could not spot an organic pathology. It's out of our scope today, but the main difference between organic and functional disorders is the red flags. Red flags is always there when you want to suspect organic disorders. A quick summary of the red flags: family history of GIT diseases or of chronic infections, constitutional symptoms as weight loss is on top, of course, and fever, persistent or localized abdominal pain, upper GIT symptoms as the vomiting, bowel changes, diarrhea or constipation, any GIT blood loss, upper or lower, presence of organomegaly or extraintestinal manifestations, especially the skin manifestations. And going back to this patient, to our patient had multiple red flags from the history. Fulton growth is one important red flag, fever, pain was localized to the right side of his abdomen, organomegaly, he had hepatosplenomegaly, and skin manifestations. I could not categorize it in tuberculous patients and not on IBD patients, but again, he had skin manifestations as an extraintestinal sign. So how to proceed? We have basic investigation checklist, which we call limited investigations. These are the baseline bloods, CBC, CRP, ESR, electrolytes, liver, renal functions, urine and stool. So this is baseline limited investigations. And then we have more targeted investigations in which we're looking for a serious involvement of the GI. Occult blood and stool, fecal calprotectin, fecal elastase and pancreatic enzyme for pancreatic pathology, celiac serology, because celiac disease have a very wide array of presentations, not only the typical malabsorption picture. And then we have a list of other imaging techniques, barium, CT, MRI, or MRE, and ultrasound even. And finally, we can look inside the GI through endoscopy and biopsy. In our patients, he had derangement in his CBC, CRP, and ESR, which could not point out to a specific pathology. And he also had a peculiar picture in his ultrasound and CT, and this was the second elephant in the room. I'm not sure if this shows or not. This was the second elephant in the room. The second elephant in the room was what was shown in his CT picture, the ileocecal thickening. Ileocecal thickening is never an easy sign to see in any radiology for a patient with fever, abdominal pain, and weight loss. It's very serious and it's very challenging as well. Why? Because the ileocecal area, it refers to the cecum, the ileum, the ileocecal valve, the appendix. So this is all by itself is the ileocecal area. The ileocecal area in GIT diseases is a perfect crime scene. Why a perfect crime scene? Because it's an area of physiological stasis. It's an area in which there is very rich lymphoid tissue. So whenever there is process of infection, inflammation, neoplasia, the ileocecal area is almost always involved. And that's why it's very challenging. The arrows here point, of course, to the thickening in the ileum, thickening the ileum and proximal cecum. So whenever there's ileocecal thickening in imaging, we have to think of one of three. It's either infections, inflammatory pathologies, or neoplasm. These are the three top. There are many other, there's a very long list, but on top are these three: infections, inflammatory, and neoplasm. On top of the infection is abdominal tuberculosis. Although other infections might be there, Yersinia, Campylobacter, I see COVID-19 here as well. But the main difference between TB as infection and the other infections is that TB runs a longer course. The other infections usually have an acute presentation. On top of inflammatory pathologies are the inflammatory bowel disease, or mainly the Crohn's, of course, and neoplasm in the younger age is lymphoma, although we can see any kind of tumor at any age. If this is challenging, if characterization, whether it's infection, inflammatory, or neoplasm, is challenging, so it's almost more challenging to say, is it abdominal TB or Crohn's disease? This is even more challenging. Because both abdominal TB and Crohn's disease share this very famous trio of fever, right lower quadrant abdominal pain, and weight loss. There are few symptoms, the signs that go more with tuberculous infection. Of course, if there's history of a contact with the tuberculosis, if there is lung involvement, so it's more toward the TB side. If there's a picture of effusion, pleural, pericardial, or ascites, so it's more towards the tuberculous side. And of course, if there are nice sweats. More towards the Crohn's disease is a longer duration of the pathology. So usually patients of Crohn's disease present 4, 5, 6 months after start of the symptoms. Presence of bloody diarrhea is with Crohn's disease. Perianal pathology or extraintestinal manifestation goes with Crohn's disease more. If I go back to our patient had lung involvement evident on clinical basis as well as CT, and he had effusion, pericardial and pleural as well. But the duration of disease was not very long, not to think of Crohn's disease. And again, he has skin manifestations not typical of IBD, but I might consider some extraintestinal affection as well. So we're confused. Is it TB or Crohn's disease? So can we do endoscopy? Can endoscopy be the answer? The arrows point out to the abnormalities here. On the left-hand side of the screen, the red arrows show severe inflammation of the ileum, of the terminal ileum and the cecum, with polypoid masses, picture of polyps. And then on the right-hand side, the green arrow show ulcers. The yellow arrow underneath show ulcers. upwards. I'm not sure about the colors anymore, but it shows severe inflammation. You might think that this is pictures of one patient. Actually, these are 3 different patients, one with TB, one with Crohn's disease, one with one with the amoebiasis causing cecal ulceration. So what's the conclusion here? The conclusion is that the endoscopic picture, the gross endoscopic picture, does not tell you much, does not differentiate. What about the histopathology? The hallmark of tuberculous infection and of Crohn's disease is chronic granulomatous pathology. The TB, there is caseation, and the arrows here point to caseation, caseation necrosis. But actually, this is textbook. This doesn't happen in real life. In real life, it's very unusual for the histopathologist to say this is caseation necrosis or TB, or this is an epithelioid granuloma of Crohn's disease. This is very unlikely. And it's even more unlikely for a biopsy or a smear and culture to show the acid-fast bacilli of the TB. The limitations are huge, not only the experience of the histopathologist, but also the limitation of the staining and the technique by which the biopsy was taken. So again, the biopsy does not tell you much. You need to be very lucky to find this criteria for diagnosis. What about bloods or baseline laboratory investigations in general? The baseline bloods, as we see in this case, the CBC, the CRP, the ESR, does not tell you much. It's all non-specific. It's chronic inflammation or inflammatory process. If I do serology for celiac disease, for Crohn's disease, the ASCA by name, again, it's not conclusive. Most of cases with Crohn's disease do not show positive or high titer of ASCA. What about the PCR, the quantiferone, the adenosine deaminase, whatever, more sophisticated test to test for TB? Before this slide, the idea of the quantiferone is that it investigates or tests the interferon gamma response. And the interferon gamma response is highlighted or takes an upper hand in cases of Crohn's and also in cases of latent TB. So if you find a positive quantiferon, it does not tell you that your patient is 100% TB, but it increases your suspicion that this patient might be TB. And this paper shows that there's always possible false positive quantiferon test in patients with IBD. This is very true. So we're confused, right? Is it TB or Crohn's? The whole world is confused. It's not our case. It is a big confusion. Let me take you back at the global burden of the disease, the global burden of pediatric TB versus the global burden of pediatric IBD. Pediatric TB can reach up to 0.3%, 1 million per year. 0.3% is intestinal, and these data are from India, regarded as the international hub for tuberculosis. The burden of pediatric IBD might reach up to 2.3%, and it's on the rise, of course. Abdominal TB is very unlikely to happen in a host who is not previously immune compromised or having a chronic debilitated illness. It's not usual. It's not usual to see cases with abdominal TB in a previously healthy individual. It could be primary, of course, or secondary tuberculosis. Abdominal, primary ingestion of the unpasteurized milk, and in our case it was not valid, or secondary spread hematogenous or from adjacent lymph nodes in a case of open pulmonary TB. Abdominal TB could affect the lymph node, could affect the peritoneum, could affect the intestine. And if this happens, it will happen always on the right side, which, as I told you, is the perfect crime scene for every GI diseases, or it could happen in solid organs at the liver and the spleen. Intestinal TB could have various presentation, acute, and hopefully our patient was not like this, where it presents with peritonitis, perforation, picture of acute intestinal obstruction, or it could run a more protracted, prolonged course in which it presents with the famous trio of fever, abdominal pain, and weight loss, just as our patient presented. So is it intestinal TB or Crohn's disease? No one knows. No one knows. You should have a very high clinical suspicion, and the differentiating points are very few, just as I highlighted before. Again, the differentiating points based on the labs, the imaging and histopathology, you need to be very lucky to prove it. And the best is the response to the antituberculous therapy. So the best is to monitor your patient and follow up the response to antituberculous therapy. This is a very, very interesting algorithm. It's the agent-specific consensus on Crohn's disease, actually. So I'll start from here, and I added some points just to follow with me. There is always a diagnostic confusion. So if you're confused, if you're not sure if your patient is Crohn's disease or intestinal TB, so it's better to start treatment as intestinal TB. So you start antituberculous therapy, and then you have to follow up the clinical response after 2 to 3 months. You have to follow up the response of your patient. If your patient is not improving, if the clinical response is poor, you have to redo the endoscopy. If at the mucosal level or at the histopathological level, the disease is still active, there is still chronic granulomatous process, there is still cryptitis or inflammation, probably your patient was Crohn's disease who was falsely labeled as a case of intestinal TB. So if the response was bad and the endoscopy and histopathology show quiescence, the disease is not active, so probably your patient is TB, but he's having a complication as a stricture, or he might be a multi-drug resistance TB. So this is one side. The other side of the story, if you start the antituberculous and you follow up the clinical response within 2 to 3 months, and the patient is clinically improving, just like our patient, the fever subsided, the appetite is better, he started gaining weight, so leave him for another 3 months and redo the endoscopy after 6 months of therapy. Usually therapy for intestinal TB takes from 12 to 18 months. So you follow up the clinical response. After 6 months by an endoscopy, you have to do an endoscopy because this clinical improvement should be coupled with a mucosal healing by endoscopy and histopathology. If the patient still having active disease on endoscopy and biopsy, so there is still inflammation and ulceration and polypoid masses, and the histopathology still shows activity. So again, your patient was a Crohn's patient who was falsely labeled as intestinal TB, and you have to change the whole plan of management. But after clinical improvement and endoscopic improvement, there is healing at the mucosal level. So you were right from the very start, and your instinct was perfectly right, and this was a case of intestinal tuberculosis. So I'm so sorry to tell you this, that this case is not a closed case to me. We still need to follow up. We still need to follow up the response to antituberculous therapy clinically after 3 months, endoscopically and histopathologically after 6 months. So after 6 months doing an endoscope, which unfortunately was not done from the very start, should give you more clear answers. Thank you very much. Thank you.
Thank you very much, Professor Marwa. That was very educational, may I say.
Thank you.
I'd like to thank our last 2 speakers actually for giving us a lesson on how to follow clinical and radiological clues and how to use your clinical decision making, and for very valuable clinical pearls that we've been taught today. I'll hand over to my co-panelist, Professor Ilham, to present our next speaker.
I